A major focus of mine outside of actually just doing surgery has been the whole industrial process stuff behind practice improvement and reducing variation, the clinical standardisation. So this is how best I encapsulate it, is the strategy has been using measurable quality as a strategy to manage a surgical division. So to do that, you firstly have to define quality, you have to be able to measure it, and then the methods we've used is defining best practice, eliminating waste, deliberate system design, standardisation, along with an agreed improvement method, and then strategies to sustain. And we all talk about we're going to produce quality healthcare without really having a shared understanding of what quality healthcare means. And it's actually one of my favourite questions in an interview. And I've been on panels where I've interviewed CEOs and they've gone along, put people to be a CEO. And they've gone along and then I've said, well, how do you define quality? And generally, they're completely floored by the question and don't really have a easily definable concept or how indeed you might measure it. So the way we do it, we decided this in the division years ago, and now it's the network-wide thing, that we use the Institute of Medicine definition of quality. So just before I get to the definition, the amount of information that's available at the moment is absolutely massive. There's massive amounts of stuff out there. And even a guy in 1992 and then subsequently Gawande, the volume and complexity of what we know has exceeded our individual human capacity to process and deliver. And so this guy, who I think is executive chairman at some place in the United States, there were 5 exabytes of information created between the dawn of civilization to 2003, but that much information is now created every 2 days. May or may not be accurate, but it gives you an idea of the magnitude of the problem. So there's safety, the Hippocratic Oath, first do no harm, but we need to move beyond that, and this is the way we talk about it, is ensuring all patients receive appropriate care. So we call it quality beyond safety. We do spend a lot of time over there with subject, discipline, values, professional knowledge, but very little on the right-hand side, improvement knowledge, learning about processes, systems, variation, psychology, etc. And we need to balance what we know on the left side with the principles and processes that are involved on the right side. So these are the domains of quality that we talk about. Safe is one of them. Efficient, so that's the financial side, if you like. Effectiveness, that what we're doing has the intended effects. Acceptable, so that's the patient experience side of it. Accessible, that's equality of access. Appropriateness, that what we're doing, that what we're delivering is appropriate for the needs, and obviously all of those things being patient-centred. And it is possible. So if you think of that, it actually covers. I'll just move to the next slide. There are the definitions written out. It does cover everything, and it's quite easy to use these things to develop effective measures. Now, what we find happens a lot in healthcare is that a lot of our stuff is time-based. A lot of the targets, a lot of the so-called quality measures are time-based, because time-based is easier to measure, not because it's the most appropriate, and that creates its own set of problems. So let's just look at some quality studies that have been done. This is a real landmark published in 2003 in the New England Journal of Medicine, the quality of healthcare delivered to adults in the United States. So 439 quality indicators across 25 conditions, a variety of methods to do this, but nearly 7,000 participants and nearly 100,000 events. So in any language, that is a massive study. And just to show the range of conditions and then the percentage of care recommended care received. Cataracts were the best, and so went down. Hip fracture and alcohol dependence, you were lucky if you got anything correct. But overall, it was about 55%. So the percentage of recommended care received was just over half. So that's in the appropriateness domain, okay? Now, if we move on, a really important thing that they identified here was that the greatest proportion of errors were those of omission, things that should have been done not being done. Not so much errors of commission, where care was delivered that was not appropriate or potentially harmful. So nearly half versus around 10 or 11%. The quality of healthcare study, the first quality of healthcare study in Australia, published in 1995 in the Medical Journal of Australia, so I only put this up for the same thing, it's found the same thing, that the biggest proportion of errors were errors of omission, although errors of commission were a little higher in this study. This was on patients in South Australia and New South Wales. Then they did another study in Australia, similar people doing it. The name Geoffrey Braithwaite is, he's a real sort of guru of quality healthcare systems in Australia from Macquarie University. And you'll notice the second to last name, Beth McGlynn, is the lady who was the senior author on the American paper. So they got her involved to help them with this study. Peter Hibbert, whose name's in the middle there, does help us down here with various things at times. Peter's based at Uni SA in the city. Anyway, they repeated that American study and published it in 2012 and found a very similar result. So 10 years later, 57% of encounters in the sample received appropriate care, which, and similar thing, there was compliance being as high as 80% for some and low as 32% for others. So a very similar result to the United States study. In other words, in the 10-year period, nothing much had improved, and that's just the range of conditions and then the chart demonstrating the percentages of appropriate care received. One of the really interesting things that they discovered in this paper was not only was the overall compliance 57%, but for things where appropriate care was well defined with level 1 or level 2 evidence and grade A or B recommendations, so the highest level of evidence available, it was still only around the 55% mark. So in other words, level 1 evidence, meta-analyses and all the rest of it made no damn difference to the reliability of the care delivered, which is an extraordinary finding. Now, I'm going to show you a study done a long time ago, published in JAMA in 2000, and this is a group of American hospitals, and what they were trying to do in this study was demonstrate that care in a university hospital for acute MI was more reliably delivered than in a minor teaching hospital or a non-teaching hospital. And so they are giving it of aspirin, ACE inhibitors, beta blockers, and appropriate reperfusion. And so yes, they discovered that in the major teaching or university hospital, there was a higher degree of reliability with the first three things and no particular difference in the reperfusion, but sort of quite remarkably low results with the reperfusion. So yes, they proved their point, but there's still some pretty big deficits there, remarkable deficits in fact. Now, there's an organisation in the United States called Intermountain Healthcare where a guy called Brent James had spent a lot of time doing exactly the stuff, looking at systems, trying to eliminate variation and developing clinical protocols to overcome that issue of the errors of omission to try and make healthcare delivery more reliable. And they did the same study in their cohort of patients, and what they discovered, superimposing their results here, is that in their systems, the appropriate care delivery was between 90 to 96 or 94 to 96%. much more reliable than in those other hospitals. So that's a remarkably different and better result. So in essence, what we have tried to do is emulate the Intermountain Healthcare product, the blue. To demonstrate that in our system there is clinical variation, cardiology did a study, 12 months of data, 2011, and they looked at all the cardiology type presentations, divided them into three groups: acute coronary syndrome, the ischemia, heart failure, and arrhythmia. And the patients were randomly admitted, they'd come into hospital, go through the ED and admitted under the cardiologist on duty for the evening. And then they looked at what happened according to the subspecialty interest of the cardiologist, whether the cardiologist was an interventionalist, in other words, did the angios, whether the cardiologist was a heart failure doctor, or whether they were electrophysiologist, in other words, looked after arrhythmia. And what they found is, so the one on the left is acute coronary syndrome care according to whether they're admitted under an interventionalist or a non-interventionalist. Similarly, the next one, heart failure care, a heart failure specialist, a non-heart failure specialist, and arrhythmia, or atrial fibrillation in this case, an electrophysiologist or a non-electrophysiologist. And in the red are highlighted some of the differences in outcome. So the length of stay, 3.19 versus 5.52. But look at the 30-day mortality, 1.14 versus 3.69. That's sort of a threefold difference, which is quite something in a group of 1,300 odd patients. And then you look at heart failure, the 30-day readmission rate, but look at the 30-day death rate, 1.52 versus 10.38, an extraordinary difference. And in the other one, the 30-day readmission rate, 14% versus 26%. So really quite significant differences, demonstrating significant variation in practice according to subspecialty interest. So the question then becomes, how do you actually flatten this out? Because what they thought was it didn't matter which cardiologist, which a patient was admitted under, they would get the same care. Clearly not true. Fairly confronting one way or another. Now this is not a straightforward study to do, and I must recognise Derek Chu, who shared these results with me and has allowed me to present them. I think it's a really a sort of a bit of a landmark thing within the organisation. Now what they did was then attempt to stream the patients to come under the right doctors. My response to this would be quite different, and I'll explain what it would be. So the science of quality improvement, how do we actually implement best practice? How do we ensure reliability? And of course, how do we change care when required? And this is not straightforward because of the massive amount of information, the variation between individual medical staff, not patients, different practices, different policies, all sorts of different things. And when you're conglomerating all those within an organisation, it is not surprising that patient journeys are highly variable. So this is Brent James, this is the real guru. So I went to a course where he spoke for 3 days, and it was sort of amazing because I thought, wow, you know, this is and this was just after I'd become head of division. And he really turned the light on. I thought, you know what, this is how we need to do stuff. And this was the New South Wales course for practice improvement. So it was something I went on not really knowing what would come of it, but what came of it was this was the way we are going to do business. So if I move to the standardisation bit for a start, so our two pillars were the standardisation and improvement method, and adopting a standard improvement methodology which helps us to understand what the problem is, understand what's causing it, and then develop solutions and measure what happens. I'm not going to talk in detail about what that process is, or we'll be here till tomorrow. But so Josh, you're involved in a project that's doing this at the moment. So it's not until you start doing projects like that that you start to understand the process improvement thing. But clinical standardisation, simply put, strategy to reduce error and administer best practice clinical care. It's also designed to reduce variation, of course, and it's based on the fact that studies indicate the most significant quality of omission is, a defect is omission. Now, you've seen this before, but this is a B-17 American bomber, World War II. Something like 14,000 of these produced. A highly reliable aeroplane, in fact, could withstand enormous damage from outside agencies, generally Messerschmitts and things. But it would still allow it to fly. It was quite a remarkable aeroplane. But in about 1932, there was a fly-off in America between prototypes of bombers from various companies, Boeing de Havilland, whoever else. And that's what happened to the prototype of the Flying Fortress. It took off and then immediately crashed and killed the pilot and the co-pilot. They didn't have the full complement of crew and all the rest of it. This was a prototype. But despite this, they ended up getting to where they did. And so what actually happened? Well, they examined what had gone on and discovered that the Flying Fortress was a very difficult plane to pilot, and the pilot on this occasion was the most experienced test pilot in the US Air Force. Had to attend to 4 engines, each with its own fuel oil mix. I mean, wow. One of the first planes with retractable landing gear, wing flaps, electric trim tabs for stability, constant speed propellers, but you adjust the pitch with hydraulics. And the pilot on this occasion forgot to release a locking mechanism on the elevator and rudder controls, so couldn't control the plane, and that was the result. So what they did was develop, and this is the first recorded checklist, was develop a Flying Fortress checklist and then flew a large number of miles without any further incidents. And if any of you've flown in a light aircraft, you'll see the pilot sitting there with a flip chart, and you think, don't they know what to do? But actually, it's the aide de memoire. It's making sure that all the steps are visible, because relying on the human mind to remember everything is a highly unreliable thing to do. So that was the origin of the checklist. It's now used in building skyscrapers, nuclear navy. I mean, so many different enterprises. I read this article in the New Yorker written by Ada Gawande in 2007, and it was really, really informative. But what he did, he referred to the original development of a checklist in medicine, which was at Johns Hopkins Hospital in the United States, and a guy called Peter Provenost, who's still running around talking about this stuff, they'd noticed that there was a very high sepsis rate in patients in whom central lines had been put in for whatever reason. So it was something like 11%, which is a highly morbid thing. I mean, they get septicemia, you can get damaged heart valves, endocarditis, and not infrequently death. So they developed an insertion protocol that involved full scrubbing, preparation of the patient, all this sort of thing. And the nursing staff observed the doctors and halted the process if there was a protocol violation. And remarkably, over the next 15 months, there were 2 infections only. A dramatic decrease by standardisation and adherence to a standard. They tested other checklists in the ICU, ventilated patient pneumonia, GI hemorrhage prophylaxis, with the same sort of results. In other words, they were suddenly a far more reliable, safe, quality system. But as with any of these things, it was very difficult to spread this to other organisations. No one believes you can't. You know, if you're at Mayo, you don't believe the Hopkins, or if you're at Flinders, you don't believe Royal Adelaide, and vice versa. You know, same sort of thing. So, and these are Brent James' words, protocols are opportunities to mass customise. The basic protocol provides around 80% of the standard treatment and 15% is varied, but it's not the same 85% and 15% for each patient. It's different. And that's where you need the expert workforce. You can't put a novice in here and expect everything to happen exactly the same as an expert. The expert needs to still make decisions, but with as much information in front of them as enough to allow the performance. So execution by expert workforce is essential. And this is our process for it: document what happens now, review the evidence, gain consensus from the group of consultants. There may be many right ways, but the process is to determine an agreed way. Now, I give a ridiculous example of this. Is anyone aware of any evidence to suggest that it's safer to drive on the left-hand side of the road than the right-hand side of the road? Which is better, left or right?
Depends what country you're driving in, I think.
Do we know? Do we know? Are accidents more prevalent in countries that drive on the left-hand side of the road or the right-hand side of the road?
Do we have data for it?
Hey?
Do we have data for it? Like the last 20 years, do we have
There is, yeah, of course, because we know what accident rates are in different countries, and we know what mortality is like. Now there are other factors, obviously. I mean, if you're driving around in Mumbai, it's slightly different to driving in Adelaide, but there is no evidence to suggest that left or right is superior. But imagine what would happen if we allowed everyone to choose which side of the road they would like to drive on, because they prefer, you might prefer to drive on the right, or you might prefer. Clearly a ridiculous example, but you get the idea. There may be many right ways to do it, and it's the same in healthcare. There's not necessarily an absolute right way, but if we all do it differently, and no one knows what the plan is, when it's filtering down through junior staff, nursing staff, and other medical practitioners, chaos reigns. So the whole idea is that we develop a way that this is what we agree to here, and variation occurs according to clinical need, not individual doctor preference. So you need to determine what evidence is, and for the majority of decisions we make, there is not level 1 evidence. There is not multiple randomised trials and meta-analyses demonstrating a very clear advantage of one thing over another. And you think, managing any patient, there are multiple decision points, and the vast majority of those decision points do not have the level 1 evidence. However, we still need to define a way, or define what we will do, which antibiotics we will use, not all using our own preference and random selection. So the interesting observation, though, in that Australian study was it didn't matter what the level of evidence was, the degree of reliability was no better. So that's even stronger evidence to develop your standard operating procedures if you wish. I won't go into this in great length, but no protocol fits every patient, and accordingly not every patient fits a protocol. You choose your larger groups or the more complex ones. In fact, the way to break down complexity, people say, you can't do it because of complexity. Rubbish. The way to break down complexity is to have more protocols to define each part and break it down bit by bit. And that's certainly what they do in aviation or in nuclear power or whatever, is building skyscrapers, exactly that. The protocol is the default position, but active decision making, I've said, is critical, and the measurement, but we won't go into that. We used to be able to do this. We had the protocols on the wards in yellow A4 pages. They were not allowed to be any more than one page or flip side, so it was one sheet, and they would be put in the notes. But we can't do that now, and these are not, or they're in PDF form on the EMR, but they're not in the form of decision support, which is sort of not utilising the real power of an EMR. However, we do have gone back to putting them on the end of the beds so that they can be referred to. This is just an example, probably a bit out of scope, but acute gallstone presentations, 3 groups: pancreatitis, cholecystitis and jaundice. And there were 8 of us managing at the time, all with different policies, all in different ways. So it wasn't surprising that there was chaos. But we sat down as a group and worked through this over a period of time and developed protocols for each one of those. It's a bit like the heart failure one, the acute coronary syndrome and the electrophysiology. We developed our standards for each of the 3 main groups. And we developed that 17 or 18 years ago and still follow it now. It's still as relevant now as it was then. This is a fascinating example. This is one of the first projects we ever did. Was colonoscopic surveillance in patients having colonoscopy who were at risk of colorectal cancer or adenoma. So these patients with family history, past history or something making them at higher risk. When we examined these 100 patients, we were flabbergasted to discover that we were sticking to NH and MRC recommendations about 38% or 39% of the time. In other words, we had massive defects in appropriateness. So there it is, that's where we were. So we introduced a system where we put it all, I mean, it seems so damn simple now, but we put it all on a computer and had defined rules, and we would have a nurse who would collect all the information and organise the follow-ups and all this sort of thing. And over years, and it remains like that now, we follow NH and MRC guidelines reliably almost 100% of the time. And there are something like 10,000 patients on this now. It's now actually expanded to statewide, and there are potential international ramifications, because what we have been able to discover, or what we've been able to demonstrate in this group of patients, that interval cancers in this group of screened patients are extraordinarily uncommon by comparison. So we've demonstrated an absolute survival advantage and a decreased survival, but also significantly decreased cancer rate, which has been a remarkable thing that's led now to an MRFF grant to do it statewide, and ultimately I'm suspecting nationally and beyond. But the interesting thing is that we actually brought about a reduction in surveillance endoscopy, because in a significant percentage of patients we were doing it too frequently. In other patients we were doing it too infrequently, and a significant number of patients were being lost to follow-up using routine methods. In other words, come back and see us in 5 years. I mean, who's going to do that? Who's going to remember that? So the secret was to make it reliable, but we decreased the number of outpatient visits, decreased the number of endoscopies, which increased the capacity to treat more people. So it wasn't just about increasing the facility, it was increasing the efficiency of the utilisation. So what you need is a percentage of believers, and we call them champions, but you can just I don't use that term because it sounds a bit sort of elitist. I want it to be standard, and so you don't wait for everybody to come on board, because if you wait for everybody to come on board, nothing will ever happen. And so the laggards will control the organisation. And I think that's a mistake a lot of people is to wait for all the laggards. So you get the early adopters and the silent majority who you'll be able to win their hearts and minds, but it's winning the hearts and minds through presentation of results, principle, the logic and all the rest of it, and then get on with it. Then eventually the laggards see themselves as being isolated, and they think, oh, hang on, people don't really like being an outlier, what makes laggards succeed is dragging everybody down with them, and then they think, oh, they're all part of the group. If the laggards are isolated and they then start to see themselves as outliers, they'll either leave or join in, one or the other, and you don't have to do anything else. And so I've seen that happen quite frequently. Now these results are so powerful that it's not even, it's a no-brainer, really. But yeah, it's a very real question, and you need to be persistent, but not beat people up about it. And the other thing is, you can't sort of go into an organisation, make change, and then leave and expect that it's all just going to happen. It doesn't. It's persistent, repeated presentation, demonstration, cajoling. But it's persistent effort to develop sustained change. All right. Yeah. Same thing with surveillance for Barrett's esophagus. We were getting that right 18% of the time. I mean, so I'm only showing these to demonstrate that when we actually go look, you can be absolutely shocked with the poor product that's being produced. But unless you go and deliberately look for this, you won't find it. You won't find it by doing audits and backtracking. This is front-end quality, and building in front-end quality, you need to define the standard and then measure how often you're meeting it, and then do something about changing it.
Very briefly, sorry, what would be an example of something in that process that wasn't up to standard? Is it like the times that you're doing it, you're looking for?
Okay, it was a combination of things, in fact. It was the frequency, and it was also the number of biopsies that were being taken. So it was two things. I think we've put there, that's biopsy best match, and so the target it's 4 biopsies, quadrantic biopsies every 2 centimetres, and people weren't doing that. I mean, they were only doing it 42 or 3% of the time. The other big defect was the frequency, and often doing it too much. And so doing it too frequently, you end up with a demand capacity issue, and so you can't meet what's required. This is one, don't worry too much about the name, but in people with a new diagnosis of cirrhosis need to have an endoscopy to look for varices, esophageal varices. So we were the liver transplant hospital, and sort of fancied ourselves as being able to look after these patients pretty well. And we were doing it 5% of the time. That's pretty confronting when you think, bloody hell, what a remarkably poor product that is. So really, once again, to demonstrate, unless you set the standard and then measure against that standard, you'll never discover this stuff. I'll keep moving. This is a project we did over years. So the old days, doing a bowel resection, it'd be nil orally for the first, or actually it'd be continuous nasogastric suction. Then when there were bowel sounds, you'd remove the nasogastric tube, 30 mils an hour for a day, 60 mils an hour for another day, 90 mils an hour for the next day. And so people were starved for days. And then we learnt that this was all not necessary, but it was really hard it was very hard to change people's practice, because the surgical dogma had been so powerful that to challenge surgical dogma and get people to do something different, but this is what happened. So, the average day for fluids being committed, 3.5 in 2004, day 3.5 on average, down to in 2009, day 1. Dramatic difference. And so people were not being starved and this led to, amongst other things, to decreased length of stay and whatever. 44% in decrease in average length of stay over that time period. Now, it wasn't only due to that, but the feeding was a significant factor, because here the median was 5 days going home. Well, a lot of those other patients were being starved for 5 days. ERAS is a comprehensive package of care around peri-op patients. So there's a pre-op bit, there's an intra-op bit, and there's a post-op bit. And there's somewhere, depending, 30 to 35 elements of it. And this was a study done and published in Annals of Surgery in 2015, demonstrating that if you got more than, or the major complication in any complication, the more of the ERAS items that you complied with, the less were the complications, either any or major. So that's, and this is to do with mobilisation and feeding and a whole lot of delivery of DVT prophylaxis, all that sort of thing. But the more standard you could get it with the less omissions, the better the outcomes. And we have ERAS protocols for a whole lot of conditions. And similarly, the same sort of thing with, this is just colorectal cancer rather than all of surgery, but the same sort of thing. Doing harm. So this is the project the plastic surgeons did some years ago. They discovered quite a high complication rate with breast reconstruction with prosthesis. So this was after mastectomy for breast cancer. And what they decided to do was to do exactly what Provenist had done at Johns Hopkins with the CVC line sepsis, is they defined the ideal process, the skin prep, the antibiotic, glove change, method of handling, etc., etc. Agreed and implemented by all plastic surgeons. So they sat as a group and they decided that they had identified this problem and they were going to do something to solve it for patient benefit. And that's what happened. The complication rate went from 33% down to 16%, so halved, and the infection rate from 7%. And in the 6 months, there was one infection 6 months later after a dental procedure. So it's probably a bit harsh calling that a complication, but nonetheless, a very significant reduction in infections and overall complications. So once again, a really good demonstration of defining the standard and applying the standard, signing up to it and applying it. I didn't know this was going on. They did this.
It also changes the perspectives of people working in that team, right? They're all of a sudden looking at things from different perspectives than they were before. So the whole quality of everything kind of is enhanced. Is that, would you say that?
Oh, absolutely. Yeah, and so we started off with a few protocols. We've now got something like 250, and people are sort of well signed up, not equally enthusiastically, but are well signed up to the idea of the standardisation, and then a standard process of finding, identifying, solving, instituting change. I just put this up to compare it with the results in the CareTrack study. So we've had protocols per unit for different types of patients, so different protocols, and every now and again we order compliance with the standard, but we've consistently had compliance rates around the 80%, 90% mark. In CareTrack it was 40%. So certainly we're delivering a lot higher quality. If you try and do this, if you try and measure your effectiveness by the end result, pulmonary embolus or DVT, you'll never find anything, because that doesn't particularly change. That's obvious. Patients may die at home, they may come back to the same hospital, they may go to a different hospital. There's no way of knowing. They go to different units, you don't track it. So we use a process measure rather than an outcome measure. The process measure is delivering your standard. Esophagectomy patients, we've had lots of projects to decrease the complication rate and the early mobilisation, all that sort of thing in esophagectomy patients. And so this is up to 2016, I think, just demonstrating that by doing this there was a progressive decrease in length of stay and complication rates. We did a diverticulitis study trying to decreased the admission rate for people with diverticulitis. So simple diverticulitis doesn't be admitted, people can be discharged, and over the period of time. So we were trying to get the target down a bit, and it slips every now and again. But we've managed to maintain that for a period of time. Now the thing about that is, a success rate of this is increasing the length of stay. Why would that be? So we're keeping the complicated patients and we're discharging home, not admitting the simple patients. And so the occupied bed days total decreases, so we create capacity. But if you just look at that DRG, if you will, the length of stay will go up. And this is the absurdity of one of the things that the Department of Health and other bureaucratic organisations look at, is length of stay as the holy grail. But you know what? Success sometimes is increasing it. So it's not that straightforward. This was just a study we did some years ago. One of the residents looked at about 1,200 general surgery admissions, put them all through the NESQIP calculator to determine the expected mortality and morbidity. And what we discovered was our actual was 1.4% versus, this is the mortality, versus an expected of 6.6%. We did this because we didn't have any standard to measure against, and so we wanted to use something. And so using that NESQIP, which is the American Quality in Surgery, NESQIP is that, and they've got a bank of, well, at the time it was about 1.5 million patients, and so they can predict risk or outcomes, and so that was the standard we used. Now we have no idea what how other organisations would compare, but at least we were convinced by this that our approach to standardisation and care was not doing harm, and that was fairly important. Are you all aware of the Bristol Royal Infirmary inquiry? So in the 90s, there was a scandal in the United Kingdom because the Bristol Royal Infirmary had a paediatric surgical unit, and they were doing an operation called the arterial switch, which was in kids with congenital heart disease, swapping the aorta and pulmonary artery around. I mean, it's sort of quite hairy surgery. But the mortality rate in the Bristol Royal Infirmary was terrible. And there was an anaesthetist, whose name escapes me, Steve Bolson, who blew the whistle and no one believed him. You know, it's a little bit like the case of Lucy Letby, the murdering the neonates, that the administration wouldn't believe, and whatever. And eventually it turned out she was a mass murderer. But not that these surgeons in Bristol were trying to be mass murderers, but no one would believe Steve Bolson. But eventually someone did an external review, and suddenly, wow, this is what's happening. Bolson suffered so badly from this that he actually left England and came and worked in Australia. And he went and became an anaesthetist in Barwon Health, and he's now a quality control person in a private hospital in WA. So it's been quite a journey for him. But the rules were changed in the United Kingdom as a result of all of this and certain standards and whatever. But out of it, a British human factors expert, James Reason, decided that they would study this operation done in other parts of the United Kingdom and see if they could establish patterns or markers of success. And this was done by, so 2 human factors experts would sit in the operating theatres in paediatric cardiac units in the United Kingdom, and their findings were quite remarkable because they were able to identify behavioural markers of surgical excellence, an often a not well understood field at all. And technical skill was one of them. Well, hardly surprising. That's seems fairly obvious and self-explanatory, but the rest of it not necessarily so. Mental readiness, cognitive flexibility, in other words, in a complex situation, being able to perform and solve problems and find a way out of a difficult situation. Anticipation, understanding where things might go wrong, how they might go wrong, and being prepared for that. Safety awareness. And that's more than just the bit in front of you, that's the whole operating theatre. Communication style, how they would talk to. Now, none of you've had much opportunity to be in operating theatres yet, but there is a thing in sport called white line fever. You know, people step over into the arena and suddenly become different people. You see it in operating theatres. Some surgeons behave incredibly badly in operating theatres, completely lose the plot. Yell, scream, rant, rave, throw stuff, whatever. Whereas others remain calm and communicate with people on a more egalitarian basis. And what they discovered here is that makes a difference. Team adaptation, in other words, including people and developing a team stuff, situational awareness, understanding what's going on around you and making adaptations for that. Now, 4 of the 16 surgeons studied performed at a higher level when measured with these performed better in terms of outcome, morbidity and mortality, and they all rated highly on the behavioural indices, which was the first study I've ever seen that did this. They made fewer errors, more compensations, highly adaptive to unplanned departures, and tended not to show stress. In other words, kept control and kept calm so that people around them kept calm. Whereas the lesser performing surgeons also rated consistently across the behavioural characteristics, but less well. Less likely to make compensations, did not generate new hypotheses to solve problems, had or developed cognitive tunnel vision and fixation errors, continuing to try and do it the same way and expecting to see a difference. So that's sort of a fairly remarkable study in a whole lot of ways. Interestingly, the hospitals in which the 4 high-performing surgeons worked prioritised clinical over non-clinical goals. So there was an institutional component to all of this as well. And I think we're in great danger in healthcare of losing that perspective. There were negative effects of team and organisation as well, no team stability, inexperienced junior staff, rotating scrub nurses, disruptions to the flow of operations. And what they discovered was if there were 7 minor events, suddenly the team was unable to adapt, there was a drip, drip, drip effect, and the team performance and surgeon performance deteriorated significantly, which is also a really interesting thing. I've added 2 more factors onto here, humility and self-awareness. I do go into a little bit more detail in this in a talk I do on human factors, but just to complete the ones. Now, there was some remarkable work done at Vanderbilt University where a very good friend of mine is actually the head of the whole organisation. We came from the same craft group, HPB Surgery, and I've got to know him really well. But they developed a system of recording and reporting complaints, behavioural complaints against staff, not to go and abuse the staff, but to see if they could develop all early warning signs and early intervention to go and prevent that behaviour from escalating into something uncontrollable. So they had this large database of behavioural complaints, not made by patients with adverse events, but behavioural complaints in any interaction within the organisation. And what they found was quite remarkable, that for surgeons doing more complex surgery, there was a significant correlation between the number of behavioural complaints made in the preceding 2 years and the adverse surgical events occurring in the next period of time. So that's a remarkable observation. In other words, it's another demonstration of how surgeon behaviour influences outcome in a real patient way. So it adds on to that information that was obtained from the Bristol Royal Infirmary initiated human factors research. They then repeated this study in a group of hospitals in the United States that adopted the Vanderbilt system. Same outcome. So I'm just going to show you a few things from, this is from the Division of Surgery at Flinders now, going back to from 2001 to July, we're up to that's January 23. So our elective separations, our emergency separations and total separations, but as you can see, over years it's been on the increase. However, so this is occupied bed days. The occupied bed days have not gone up in the same way as the patient presentations have. And around 2010, so the occupied bed days were going up, and then around 2010 it flattened out. And what we've managed to do is absorb the increased activity within the division with the same number of beds. So activity's gone up, but bed occupancy has remained the same. So not surprisingly, average beds used is the same. But so this is the average length of stay. It's gone down. Now, a funny observation, in around the middle of 2021, it started going up again. The length of stay started going up again. And you could speculate as to why this might be. That's real. That's not, that's not some aberration in statistics. So I think there are a few reasons for this. One is we've offloaded the easy patients. So we've offloaded simple emergency patients. We're putting through other pathways, down to Noarlunga or whatever, some of them being diverted to private hospital. And also we're outsourcing quite a lot of our easier elective surgery and keeping the complex here. So when we looked at where the biggest increase had come, it was in the elective patient. So the average length of stay of our elective cohort has gone up significantly, which is the major contributor to the increased length of stay. But the occupied bed days haven't changed. Now, so that's, if you look at patient complexity data, the complexity has gone up significantly, so my statements are justified. Divisional mortality, so I took over down here in September 2021, and it seemed that for the next year or two, mortality went up. But look at it, it's oscillating around 3%. And then progressively it's come down and now is less than 1% on a consistent basis. So definitely, whatever's been happening, we've been doing something right to be able to decrease the harm by that amount. There's a question, around, do you need to change the culture to be able to do the standardisation and the improvement work? My observation is the opposite. So I presented this at a College of Surgeons talk in 2017, and my current observation is that it's actually the introduction of the standardisation and the improvement work that's changed the culture. And there's a far more egalitarian culture in this organisation than perhaps exists at others. Now, that's not my observation. That's what people tell me when they come here from other organisations. And that's something that that we've worked pretty hard on. But it wasn't until about 2015 that it suddenly dawned on me the changes that were happening, and were happening in the senior surgical staff in particular. So that was an added bonus. Brent James didn't ever talk about that. So, what have you observed so far?
It seems a bit chaotic, people busting in and stopping things and starting things.
So, there's a patient on an operating table, anaesthetised, and the floor nurses come in to interrupt to find out how long it's going to be. The surgeon's completely distracted from the checklist, not the timeout. It's actually the surgical safety checklist that they're doing there. Look, the scrub nurse here is paying no attention whatsoever to what's going on. So let's just watch a bit further. Now, is that the time to be asking those questions? So you've got the patient anaesthetised, you're just about to plunge in the instrument. Now, are you sure this is the, have you got the ultrasound of the gallstone? I mean, wow. Okay, 3 different shows going on with no interaction or understanding. The scrub sister has stood there like a mute and not participated at all in the operation. And they'd even mentioned, you know, we may have to open. Now, a good scrub sister will get someone, go and get the open gear so it's here ready to go. So, no teamwork. Now, it's not just the nurse's fault, you know, it's the way the whole theatre's working. They're working as individuals or individual groups. They're not in any way integrated. And it was all set up right at the beginning when they weren't paying attention to the checklist, where they were all doing their own thing and not gelling as a team in that 60 seconds is all it takes. Anyway, it's just a nice little example, and I'll finish there.